Thank you for joining today's webinar, Efficacy and Safety of Ketamine and Esketamine in Bipolar Depression in a Clinical Setting. And we're honored to be joined by Dr. Samuel Wilkinson and Mia Santucci. Samuel Wilkinson is an Associate Professor of Psychiatry at the Yale School of Medicine, where he also serves as Associate Director of the Yale Depression Research Program. And Dr. Wilkinson received his Bachelor of Science degree in Mechanical Engineering from Brigham Young University, and later his medical degree from Johns Hopkins School of Medicine. He completed his residency at Yale, where he joined the faculty showing his postgraduate medical training. And Mia Santucci graduated magna cum laude from Wake Forest University with a BA in psychology. And she currently works at Yale School of Medicine in the Department of Psychiatry as a clinical research associate at the Yale Depression Research Program. I want to let everyone know that there will be a question and answer session at the end of today's talk. You may type in your questions through the Q&A section on your display at any time throughout the presentation. So Samuel and Mia, thank you so much for joining us today.
Thanks, Jake. Thanks for having us on. We're, I think, excited to talk about a really important topic, which is the use of ketamine and or esketamine in people with struggling with bipolar depression.
There we go.
So just a few disclosures from myself. I've worked with a couple companies in conducting clinical trials. This is administered through Yale. I've also received consulting from a few companies. Why don't we go to the next slide, Mia? So just a background. I think a lot of people will be familiar with this, but bipolar, there's two main forms of bipolar that are recognized in the field, bipolar 1 and bipolar 2. The main distinction between the two forms is that bipolar 1, you get into kind of full-blown mania, whereas bipolar 2, that would only be when patients get into a hypomanic state. And among patients with bipolar disorder, when they are ill, the vast majority of the time is spent in the depressed phase, around 70% of the time or so. The other 30% patients would be in a hypomanic or manic state of the illness. So just this is a busy slide. This is from a paper about 2 decades ago. On the smaller end of the sample size, but very influential paper. And one of the key takeaways here is that on average, bipolar depression is harder to treat than major depression, than people who have depression without the bipolar aspect to it. And that when patients are not on mood stabilizers and they are also treated with antidepressants, they can be much more likely to go into a hypomanic or a manic phase. So there's this this is sometimes called affective switch, or a manic switch, when something we're doing to try to treat the depression might inadvertently trip someone into a manic phase of the illness. Let's go to the next slide. The main treatment options historically, it was anti-epileptic mood stabilizers. They're kind of 3 classic ones: Lamictal, or lamotrigine, I should say, valproic acid, or carbamazepine. Carbamazepine is not used that much these days. And then, of course, lithium, which has historically a really key place in the treatment armamentarium for bipolar disorder. In the last 20 or so years, there have been a number of antipsychotics that have also shown effectiveness for bipolar depression, including olanzapine, cariprazine, aripiprazole, and quetiapine. Those have been much more commonly used in the last decade or so. Now, the caveat with those with the antipsychotics is that they can lead to a fair amount of weight gain, as well as sedation, as well as the development of diabetes. So while the current treatments, they can be very helpful and effective in helping patients lead meaningful lives, there's definitely a need to search for and further develop new treatments which are more effective, that may have less side effect profiles. So I'm just going to talk a little bit about the history of ketamine and esketamine. So this dates back to the 1950s when a pharmaceutical company was trying to develop a new anesthesia medicine, and they were targeting this specific part of the brain called the NMDA receptor, and they developed a drug called phencyclidine, which they realized was just it left patients in a very unmanageable state. Phencyclidine is now known as PCP, and it is a drug of abuse. They kind of went back to the lab and developed a molecule that was not quite as potent at the key receptor, and this was ketamine. So in the 1960s, when ketamine was first developed as an anesthesia medicine, and it quickly became popular as an anesthesia medicine because, unlike a lot of anesthesia medicines, which will decrease patients' heart rate or blood pressure, ketamine generally doesn't do that. And so it could be used out of hospital settings safely. And right at that time, the Vietnam War was going on, so there was a great need for anesthesia medicines that could be safely used outside of hospital settings when, fractures needed to be fixed and so forth. So it became fairly quickly popular because of these unique properties it had as an anesthesia medicine. It was formally approved in 1970, and about 15 years later, it gained a place on the World Health Organization list of essential medicines. Again, a large part of that is because of the unique properties it had as an anesthesia medicine that could be used safely outside of hospital settings. Now, at the same time, there was work by neuroscientists who were thinking and theorizing that the receptor that ketamine binds to, this could be a potential target for new antidepressants. And the first study that really generated a lot of interest in ketamine's rapid-acting antidepressant effects was done actually at the Veterans Hospital associated with Yale, not too far from where I'm sitting. That was published in 2000. And in some ways, it was a little unexpected, but in other ways, it fit in line with the work of some of these neuroscientists in the 80s and 90s who thought that, if we could have a drug target this glutamate receptor, then it might have antidepressant action. Now, the first report was replicated by a group at the NIH in 2006. And then in 2010, the same group at the NIH reported a trial of using ketamine, low dose ketamine, as an antidepressant in patients with bipolar depression. And this was replicated just a few years later by the same group in a different sample that showed that ketamine could have at least a single dose of ketamine could have rapid acting antidepressant effects in bipolar depression. Now, in the late 2010s, some of the key opinion leaders in the field published what they called a consensus statement on the use of ketamine for mood disorders, primarily for not bipolar depression, but what you called unipolar depression. And then a few years after that is when a very similar molecule called esketamine was approved by the FDA as a treatment for treatment-resistant depression or depression with suicidal ideation. So just as a caveat to all this talk that we are going to be talking about, medicines that are not formally approved by the FDA for the treatment of bipolar depression.
Yeah, so Dr. Wilkinson was just summarizing kind of how ketamine or esketamine has been developed to treat unipolar depression, and we're going to go through some of the trials that found its effectiveness in bipolar depression. These are all going to be IV ketamine, so not the nasal form that is FDA approved for unipolar depression. So some of the first trials were randomized controlled trials done at the NIH by the same group that replicated those first effects in unipolar depression. a relatively small sample size and a single infusion of IV ketamine, and they also required patients to remain on mood stabilization but discontinue other psychiatric medications. And across a few different scales, they saw some antidepressant effects as early as 40 minutes after the infusion and up to 3 days after that single infusion. Some other observational studies that have been done a bit larger, and again with a single infusion of ketamine in individuals with bipolar disorder who were on a mood stabilizer but still not experiencing much symptomatic relief, saw a response and remission rate of 51% and 29%. And this was up to 1 week after that first infusion. Another observational study, again with a bit of a larger sample size, that used multiple infusions. So rather than just the single ketamine infusion, this was 4 infusions over 2 weeks, with the caveat that there were never 2 treatments consecutive days, so at least 1 day between infusions. And they found a 35% response rate and a 20% remission rate per a self-report of depression, and 3 of these 66 patients did have that affective switch that Dr. Wilkinson touched on earlier, but never to full mania, just to hypomania. Some open label studies found some mixed results. This, with a relatively smaller sample size, saw pretty high response and remission rates, but like I said, only in 16 individuals, while another study actually found the opposite. So both of these were multi-infusion protocols, so not just the single infusion. And while that first study saw a pretty large symptom improvement through response and remission rates, this saw an initial decrease in depressive symptoms, but then by the end of all 9 infusions, depressive symptomology actually worsened compared to baseline, despite patients continuing to receive treatments throughout those 3 weeks. So that is pretty much everything that has examined ketamine in bipolar depression, and those were all studies, so nothing really in a clinical setting. And since esketamine is not approved by the FDA, there haven't been any clinical trials using esketamine in bipolar depression. So we have a pretty long follow-up period from a clinical real-world setting using ketamine or esketamine in bipolar depression. And we look at this through 2 different lenses, the first one being efficacy. So how does depression symptomology improve in individuals with bipolar depression when treating them with ketamine or esketamine? And additionally through a safety lens. So what is the risk of that affective switching from a depressed episode to a manic or hypomanic episode when treating bipolar with ketamine or esketamine?
So I'll just share a little bit about where this data comes from. This is it's a retrospective analysis of data that is collected as part of routine clinical care at the Yale Psychiatric Hospital. So we are part of this service, and both ketamine and esketamine have been, as I mentioned, they are not approved by the FDA for these treatments, but we sometimes use them in what's called an off-label way when we judge that the benefit outweighs the potential for risk. Whether a patient receives one or the other, at least at our clinic, it's probably not like this at most clinics. Whether a patient receives either esketamine or racemic ketamine or IV ketamine is mostly a function of, does their insurance cover one or the other, and does the patient have a preference? We do have, fortunately, insurance coverage for a number of insurance policies for ketamine, and we have almost across the board coverage for esketamine. So there are not a lot of patients at our clinic, at least, that pay out of pocket. So if patients are getting intravenous ketamine, the dosage, which is the most commonly used dosage in research, is at least, and the starting dose for clinical settings is 0.5 milligram per kilogram, which ends up being, roughly 30 to 40 milligrams, depending on how much a patient weighs. For esketamine, the nasal spray, the two main doses are 56 or 84 milligrams, and that's just based on the FDA trials that led to approval of that. During treatment, sometimes patients will experience some anxiety or nausea, and they can receive what we might sometimes call rescue medications of lorazepam, which is known as Ativan, or ondansetron, which is Zofran. And this is a little bit about what our treatment approaches look like. The first 4 weeks is what we sometimes call the acute treatment course, or the index course, where patients get treated twice a week. Now, if the treatment is helpful at the end of that month period, then we will shift to an optimization course where they don't get treated as frequently. They get treated once a week for another month or so, and then after that, if to continue to maintain them, but we will spread out the frequency of treatments. And this is very similar to the way that ECT or electroconvulsive therapy is done. And we kind of have a very similar approach for both esketamine and ketamine. But this is kind of what the schedule looks like. Once you get out to the optimization and maintenance course, there's some discretion based on how the patient is feeling and the doctor's judgment and so forth. But this is a little bit about how it's done. Now, in this particular analysis that we're looking at, we're just looking back at patients who have received treatment. We're gathering together all their clinical data and to organize it and make it useful, so we can try to make some conclusions about mainly the safety, but also the effectiveness of ketamine or esketamine in bipolar depression. So this analysis includes patients who were treated anytime between 2014 and the end of last year, basically. So patients we've probably, I don't know, treated several hundred patients during this time, if not, maybe a couple thousand. Most of them did not have a diagnosis of bipolar depression, but there were some that did have bipolar depression. So we pulled those out of our data set, the patients that had a diagnosis of bipolar depression, and we looked through their charts to identify, what were their characteristics, their sex, their age, their race, and so forth. And we used some relatively basic statistics to describe, whether their symptoms improved or not during the treatment series. So the two main assessments that we use to document symptoms and symptom severity are what are called the MADRS and the QIDS. They're commonly used in research settings and a little bit less so in clinical practice, but many clinical practices will use one or the other, sometimes both. We use both routinely, and generally this is in line with how depression improvement is measured. If someone has a response to a given treatment, that means that they will have at least a 50% improvement on a given assessment. And remission, which is essentially where they no longer meet the criteria for having depression, is when you have a MADRS score of 10 or less. Now, for the purposes of this analysis, again, this was a retrospective analysis. We're looking back through lots and lots of medical records. We looked at kind of 3 levels of severity for the manic/hypomanic phase. And if someone had a mild hypomania, that was an event that did not require any intervention, just kind of resolved on its own. Moderate hypomania required a medication change, and then a severe mania was one that required a hospitalization or visit to the emergency department. That is how we classified, which is a little bit different than how it might normally be classified if you're running a clinical trial prospectively. But this is what we thought made sense given the access to the data that we had.
So like Dr. Wilkinson said, we looked through all the patients that had been treated at IPS, and there were 45 individuals with a diagnosis of bipolar depression that received either ketamine or esketamine in that time period. One thing that we observed was while the median time, so that would be those first 4 weeks of acute treatment where you're getting treatment twice a week for 4 weeks, plus the optimization or maintenance phase was about 3 months, but it was slightly longer in esketamine than ketamine. So that would be the 4 months versus 2 months. And this is the second half of that chart, and it's showing more the severity and acuity of these patients. So they definitely had tried some other treatments and interventions, seemingly without much improvement, which is why presumably they were treated with ketamine or esketamine. We also gathered the medications that patients were on during the acute series, so during that twice a week for 4-week treatment period. And the majority of them were on one of those 3 categories that we mentioned earlier, so that being a mood stabilizer or an anticonvulsant, lithium or an antipsychotic, whereas about only half of them were receiving an antidepressant. Of those receiving an antidepressant, bupropion or Wellbutrin was the most common antidepressant. And then for our efficacy sample, so this is looking at how depressive symptomology improved over the acute series. We included all patients that had an index MADRS or QID. So those are those symptom measurement scales, and they had one before their first treatment and then just one subsequent one. And we found a 39% response rate and a 13.2% remission rate after the acute series, with symptom reduction of 10 points per the MADRS and about 8 points for the QIDS. We had the safety data available for all 45 patients in our sample, and we had a total of 518 patient months of follow-up, or 43 patient years. We didn't see any patients that experienced mania or hypomania during the acute series, but as we followed patients out during the optimization and maintenance phases, there were some events. But one thing to note is that not all of these 45 patients actually continued after the acute series. They might have just done the 8 and then not done any optimization or maintenance. But out of our total sample of 45, we had almost 30% experience a manic or hypomanic episode. Some of them experienced more than one. So we had 16 episodes, which would be about 1 event every 2.7 patient years, with a median time between that first treatment during the acute series and the presence of the first symptom that's indicating a manic or hypomanic event being 266 days, so that's around 9 months. And of these 16 events, 14 occurred while the patient was on some form of mood stabilizer, whether it be a mood stabilizer, an antipsychotic, or lithium. So again, those 3 different categories of treatments that are commonly used in bipolar depression. Around half of these events were mild, so that means that they resolved on their own, and 7 of them were moderate, so just resolving with a medication change. Most often we saw that this was an atypical antipsychotic. And then 1 of the events was severe, so we can go into that a little bit later. And out of the 13 patients that did experience a an affective switch. 10 of them are either still receiving ketamine or discontinued because of symptom improvement, and the other 3 switched to ECT following the episode that we captured in our data. So of the 16 episodes, 6 of them occurred while patients were receiving IV ketamine, and one of these was the one episode of severe mania. It happened around 5 months after their first treatment and resulted in hospitalization as well as some medication changes, and ultimately this patient switched to ECT as a treatment. For the esketamine events, there were 10 out of those total 16, and one thing that we saw is there were 2 patients that upon starting treatment actually had a diagnosis of unipolar depression, but then while they were receiving this maintenance or optimization phase, they had an initial manic or hypomanic event, which led to a re-diagnosis of bipolar depression. So at the time, both of these patients were on antidepressants, but both events were mild hypomania, so resolved on their own. So in terms of efficacy, we saw a 39% response rate. So that would be a 50% reduction in their MADRS score and a 13% remission rate. And then in terms of safety, we did not see any manic or hypomanic events occurring during the acute series. When we did see manic or hypomanic events in the maintenance or optimization phases, this was about 9 months into being treated, and most of these resolved without hospitalization, so at most just a medication change. In terms of efficacy, the response and remission rates that we found are a little bit lower than some of these randomized control trials, but it is important to note that the 2 randomized control trials we presented a little bit earlier only had a single infusion and then measured 24 hours after, whereas we have 8 infusions and measure up to 28 days after. So there is going to be a little bit of regression to the mean in terms of symptom severity. And in trials that implemented multiple infusions, which is similar to what we did, we actually do have some similar remission rates.
So I want to try to just provide a little bit of a take home as the safety. So one of the main reasons that we did this study is, one, we had access to a lot of follow-up time, as Mia mentioned, I think 43 total patient years. And one of the questions in the field is does ketamine or esketamine lead to an increase in an affective switch, or in, causing someone to become manic or hypomanic? So in prior studies, this study by a group at Toronto, the first author is Fancy, 3 out of 66 patients experienced treatment emergent hypomania during the acute series. So we didn't have any. They had 3 out of 66. All 3 of their patients were on antidepressants, and I don't know that we have a bullet point here, but one of those patients did not have a concomitant, did not have a mood stabilizer on board, as far as we can tell. But we provide a lot of follow-up, and we have, in our 43 total patient years, we have 1 case of severe mania, and then I think 15 cases of mild to moderate hypomania, which didn't really disrupt patients' lives too much. And how does this? It's hard to kind of contextualize this in the greater literature, in part because we had different ways of defining it and evaluating the severity of hypomania or mania. But I think the fact that we did not find any mania or hypomania during the acute series, during the time when people were being treated twice a week. I think this argues that in severe cases of bipolar depression where, you know, patients have tried other therapies that hasn't been helpful, there is a role here for you know, off-label ketamine or esketamine use in select cases. So we do need to try to kind of continue to report outcomes and explore this in a way to look at the safety. But a couple things. One is the relatively low event rate of, you know, one event every 2.7 years. And the fact that almost all the events were kind of mild or somewhat on the moderate side that didn't really affect patients' lives. And the fact that, you know, on average, the median time to the first event was something like 270 days after the first exposure to ketamine or esketamine. I think that, again, in the select patient, I would say that this is reasonable to approach patients like this with bipolar depression who have been refractory to other therapies. Let's go to the next slide. And this is, I guess, our last slide. So one of the limitations is that this was retrospective. This is not the same level of quality as a clinical trial that you know, looks forward in time, is prospective. This was not controlled, so this was just, you know, this was an analysis of existing data from practice patterns at our clinic and our hospital. So, you know, as is often the case, we do need to continue to look at this. But as far as a kind of broad takeaways, you know, if a patient with refractory bipolar depression who is on mood stabilizers comes in, I think it's a reasonable approach, if everything else makes sense, to try ketamine, as long as the patient is aware of the potential risks. So I think that concludes our didactic portion. We're done a little bit early, but this may mean that we have you know, a little added time for questions and answers. So hopefully that wasn't too full of jargon, but we're happy to kind of, you know, make this more translatable into what this means for patients and their families, as well as providers that are you know, interested in this question.
Yeah, well, Mia, Dr. Wilkinson, thank you so much, you know, for bringing forth these findings. I know I learned a lot. I am sure our audience did as well. And, you know, yeah, we're going to move into the question and answer portion of today's talk. So please type in your questions. We're so excited, and we're going to try to answer as many as we can today. And so the first question will be, what is currently being done for ketamine and esketamine to reach that FDA approval for treatment in bipolar depression?
I don't know that there's a company who is developing either ketamine or esketamine for bipolar depression. There was a company that was interested in bipolar depression with suicidal ideation and the use of ketamine in it. But I honestly, that was several years ago. So I don't know that there's a company that is actively developing this for FDA approval.
Good to know. And then our next question is, are there any similar studies or information on the use of ketamine or esketamine for adolescents?
For ketamine and esketamine, yes, there are some studies. These are, I think, in unipolar depression, so not bipolar depression. There is a study of intravenous ketamine done out of Yale from some colleagues that we have, that showed, you know, compared to it actually wasn't placebo. It was it was a control that you know, a single dose of IV ketamine could be, you know, very beneficial in adolescents with treatment-resistant depression. The company that manufactures esketamine, the brand name is Spravato, they are in the process, as far as I know, of trying to develop esketamine and get it approved for adolescent treatment-resistant depression. So that is ongoing. I think they are in the midst of their phase 3 study, which is the final phase before FDA approval. So that's just a little bit of an update of where things are for adolescents.
Very interesting. Thank you for that. And our next question reads, what is the difference between esketamine and ketamine?
That's a good question. And there's a lot of controversy as to whether there is a meaningful difference. I can tell you the chemical difference. The chemical difference is that racemic ketamine is made of, or just straight ketamine is made of a 50-50 mix of two molecules. One is called esketamine and the other is called R-ketamine. And they're very similar. So ketamine has esketamine, but esketamine does not have the other part of ketamine. So now, what does this mean practically? You know, the main difference is esketamine has FDA approval for depression. And so at most clinics, you're much more likely to have insurance pay for your treatments if it's esketamine composed to IV, as opposed to IV ketamine. Esketamine on average is much more expensive than ketamine, but again, because of insurance, most of that cost differential is generally borne by the insurance company. So to most patients, esketamine is going to be cheaper, even though it costs more for the whole system. IV ketamine is generally going to be much more expensive. It's rare to get insurance coverage for IV ketamine for patients. So most, for most people, it's kind of out of reach financially. But again, the good thing is that esketamine, most places will have insurance pay for it. So those are some of the practical differences. Another practical difference is that because esketamine is FDA approved, it's regulated much more so than IV ketamine. Okay.
Thank you. And our next question is a two-parter. So the first part will read, do you have data on the frequency of mixed symptoms such as agitation, distractibility, and irritability in this pool of patients? And is ketamine or esketamine shown to be effective for mixed symptoms in bipolar disorder?
As far as I know, it's not been examined for mixed symptoms. Because this was a retrospective analysis, we didn't really have the ability to parse that out very well. We just kind of put everything as kind of mild hypomania, moderate hypomania, and then that did include some irritability and other things like that are kind of more along the lines of mixed phase. So unfortunately I don't have a lot to add to that, but it hasn't been studied rigorously as far as I know.
Thank you. Our next question is, it reads, what would be a safe maintenance dose, possibly 1 time a month, and how long could that safely continue? This attendee is concerned that their provider has never brought up ending treatment.
Yeah, that's a really good question. And we have the most data, the most long-term data with esketamine, the FDA-approved version of this. And, those studies, they will sometimes, they'll go for several years. So they're patients who have been evaluated. They'll have esketamine at least once a month, if not twice a month, or maybe even weekly, for 3, 4, even 5 years. And as far as we can tell, there aren't really any untoward long-term side effects. And what people worry about, a couple things. One of them is cognitive impairment. So we know that at high doses and high frequencies, ketamine is not good for your brain. And we know this from animal studies and also from ketamine, as many people here know, it can be abused and used recreationally. And when we study those people who abuse it and take it several times a week at high doses, after a year, they will have noticeable impacts on their thinking abilities, their cognitive abilities. They'll be, the memory will be impaired and so forth. When you're doing it like once a week or once every other week or less frequently at the FDA-approved doses, that does not appear to happen. Okay, so that's a good thing. Now, if you're a patient or family, and you're getting esketamine in a maintenance phase, where it's like once a month or once every 3 weeks or so, and you're concerned, talk with your doctor. For us, what we will try to do is if the patient's doing well, the patient's in remission, they're not really having significant symptoms. After a good, 4, 6, 8 months of remission, it's kind of it should be a collaborative decision between the doctor and the patient as to whether you stop, whether you keep going. If you're in remission, it's very reasonable to discontinue treatment if you've had remission for at least 4, 6 months or so. So I hope that answers some of the questions about long-term safety, as well as when might it be appropriate to stop maintenance if the medication has been really helpful.
Thank you very much. And so our next question is more towards unipolar depression. And it says, do you foresee IV ketamine getting FDA approved for depression like esketamine? And why hasn't it been FDA approved?
Well, that's a good question. 5 years ago, I would have said absolutely, I don't foresee it being FDA approved, but I think some things have changed. The reason has to do with the way that our system is set up for developing new drugs and therapies. And the reason is that ketamine has been around for a long, long time in another area, which is anesthesia. And so it's difficult for a company to develop it and then be able to have exclusivity or patent it, and then make money on it. That if a company is not willing to develop it, then the drug will not get FDA approved. Now, I think there is some interest among some companies for getting ketamine or something like ketamine approved. It's not going to be in the next year. If anything, it would be a couple years down the road.
Thank you. And our next question is there any comparison between the hypomanic or manic episodes, with the ketamine esketamine treatment versus patients who did not receive ketamine or esketamine?
Not in our analysis. I think what the question is getting at is, does ketamine, you have two groups of patients who are otherwise identical. One gets ketamine, the other doesn't. Are you going to have different either types of mania or hypomania, or you're going to have different frequencies? Is ketamine more likely to cause people to become manic or hypomanic? And we just don't know that because there hasn't been a large enough randomized trial. We can try to make some inferences based on these studies that have been done, where it's a single group, like the ones that we did. But there hasn't been a study looking at, manic episodes when people are getting ketamine versus when they're not. That'd be a tricky study to fund and also to design and to conduct.
Mm-hmm. And our next question is there any significant difference between remission rates in patients with bipolar disorder type 1 and bipolar disorder type 2?
If using ketamine, I don't know that question's been looked at in a rigorous enough way.
Well, thank you very much for that. And our next question is, when it comes to ketamine versus ketamine, it's still in the same question area as bipolar 1 versus bipolar 2. Has either ketamine or esketamine been proven to work better with either 1 or 2?
No, that study has not been done.
Excellent. And do you plan or know of any other studies that are in progress for ketamine or esketamine?
Yeah, there are a number that are in progress. We are about to launch a study looking at the comparison between the two, ketamine versus esketamine, because there's a lot of different opinions as to whether there's a meaningful difference. That will not be in bipolar depression. It will be in unipolar depression. There are Again, esketamine, as far as I'm aware, the last I heard, esketamine is being developed for adolescent depression. So that would be FDA approved if all goes well. And there are a number of other studies. If people are really interested, they could go to clinicaltrials.gov and search, any clinical trial that's legitimate in the United States has to be listed on that, even like by the time it starts. So I imagine there's a number of other smaller studies of ketamine or esketamine going on, some of which I'm not aware of.
Well, excellent. It's always good to know, the future of which studies are being directed. And as treatment continues to advance, it is something to keep an eye on. And as Dr. Wilkinson just said, clinicaltrials.gov is a good place to search for these trials. And, that's the last of our questions for today. Mia, Dr. Wilkinson, I want to thank you so much. We send our deepest appreciation for you two taking the time out of your day to share this information with our audience and, to provide education and hope on what the future holds for treatment in bipolar disorder depression. And I'd like to ask if either of you have any closing comments.
Appreciate you having us on, and hopefully this has been helpful for patients and families and providers. So.
Yeah, thank you so much.
Of course, and I want to let all attendees know that this webinar will be uploaded to ibpf.org under our educational videos tab. And please email info@ibpf.org with any feedback. We'd love to hear it. With that being said, I hope everyone has a fantastic day. Dr. Wilkinson, Mia, thank you so much and take care.
Thanks, Jake. Take care.
Thanks.